In this voice note, we're going to cover the interpretation of abdominal x-rays. However, before I begin, I would like to briefly go through indications to perform an abdominal x-ray. And these are really just three. The most common is the evaluation of bowel gas, whether or not your patient has a bowel obstruction or an ileus. There's also the evaluation of radio-opaque lines and tubes, such as the positioning of feeding tubes or if you've placed a femoral CVP. And the last real indication is the evaluation of radio-opaque foreign bodies. Abdominal x-rays are not good for the assessment of solid organs, intra-abdominal fluid collections, or non-calcified retroperitoneal pathology. For suspected perforated viscus, such as with a perforated peptic ulcer, an erect chest x-ray should rather be performed, except when the patient maybe has undergone an ERCP and there's a suspicion of a duodenal perforation, as this perforation is into the retroperitoneum and will not be seen on an erect chest x-ray. Types of projections of an abdominal x-ray. These are also three. So the most common is supine. So in other words, the patient is lying on their back. There will be no discernible air fluid levels in this view, but you would be able to see distended bowel. An erect abdominal x-ray is where the patient stands in front of the x-ray machine. This image visualizes air fluid levels the best, as well as free or intraperitoneal air. However, the patient must be well enough to be able to stand for about 10 minutes to have this investigation. A decubitus or lateral shoot-through is an alternative to an erect abdominal x-ray. The patient lies with their side down to the table and the x-ray beam enters anteriorly. This view commonly is used to detect free or intraperitoneal air in a patient who is too ill to stand for an erect chest x-ray. However, time should be allowed to allow for any gas to rise to the non-dependent region of the abdomen. Start interpreting abdominal x-ray. Well, actually, any radiological investigation by first confirming the details of the x-ray. Look for the patient's details. Is it the correct name? Is it the correct hospital number or other identification number? Check the date as well as the time of the film taken and ensure that it is the x-ray that you want to look at. And ensure that the x-ray is adequate. The whole abdomen should be visible from the diaphragms to the pelvis. The exposure must also be adequate. You should be able to see the small and large bowel features, and you should be able to see the bones of the spine. It is important to have a systematic approach to interpreting the findings of an x-ray, and this includes abdominal x-rays. I'm going to give you two approaches. The most common approach is the ABDOX, or the AbdoX approach. A stands for air pattern. Air should always be in the lumen of the bowel, and it also includes the lung bases and inguinal areas. B means bowel, which I will go through in more detail in the second voice note. D refers to dense structures, bones and calcified areas. You should be able to see the pelvis with the proximal femurs, the vertebra and ribs. Calcifications could be gallstones in the right upper quadrant, kidney stones, chronic pancreatitis, vascular atherosclerotic calcifications, and of course don't forget costochondral calcification as the patient gets older. O stands for organs and soft tissues. You can see the outlines of the liver, the spleen, and the kidneys. The liver is the shadow in the right upper quadrant, the spleen is the shadow in the left upper quadrant, and you can only really identify organomegaly, but you cannot identify the cause of organ enlargement. Both kidneys are often visible. The right kidney is lower than the left due to the presence of the liver on the right. The gastric bubble is seen in the left upper quadrant. The psoas muscles may be visible and are marked by a relatively straight line either side of the lumbar vertebra down to the sacrum. The bladder may or may not be seen as a shadow in the pelvis depending on the fullness of thereof. Lung bases should be inspected for pathology, specifically consolidation as well as effusions, as abdominal pain can in some cases be caused by basal pneumonias. X stands for external objects. This refers to foreign bodies, lines, and tubes, for example, contrast media following a barium meal, or surgical clips or staples, jewelry. The alternative approach is the BBC approach, where B stands for bowel and other organs, the second B stands for bones, and C stands for calcifications and artifacts. As bowel pathology is the most common indication for performing an abdominal X-ray, we'll go through this in a lot more detail in the second voice note. In this second voice note, I will go through small and large bowel interpretation, as well as some common radiological signs for bowel pathology. So how do you differentiate small from large bowel in an abdominal X-ray? The small bowel usually lies more centrally, while the large bowel is more peripheral, or it frames the small bowel. The small bowel's mucosal folds are known as valvulae conniventes, and these are very thin and are visible across the full width of the bowel, so they often look like stacks of coins or a spring. Features of small bowel obstruction include distensions of small bowel, usually more than 3 centimeters in diameter, and prominent valvulae conniventes, giving the coiled spring appearance. The large bowel wall has haustra. These are thick lines which do not go all around the whole circumference of the bowel wall. This distinction is unfortunately unreliable, as dilated large bowel can have haustral patterns that do in fact traverse the whole large bowel, but they are still very much wider than the thin valvulae conniventes of small bowel. The 3-6-9 rule refers to the upper limits of the normal diameter of the different segments of bowel, and the 3 is used in small bowel, the 6 is used in colon, typically the transverse colon, and 9 for the cecal pole. The cecal pole is probably the most clinically relevant measurement that we do, and once this diameter goes over 11 centimeters, we consider the cecum at high risk of perforation. Let's talk about some specific radiological signs. There's the coffee bean sign, which is a sigmoid volvulus. This originates in the left iliac fossa and usually arches into the epigastrium and right upper quadrant. The cecal embryo sign is a cecal volvulus, and the dilated cecum takes on the shape of a human embryo. It originates in the right iliac fossa pelvis, and the dilated cecal pole, or the head of the embryo, arches from the epigastrium into the right upper quadrant. So in other words, there's no distended bowel in the left, upper or lower quadrants. Riegler's double wall sign. In healthy individuals, only the inner wall of the bowel wall should be visible on an abdominal X-ray. The presence of free air within the abdomen, or pneumoperitoneum, results in air being on both sides of the wall, so in other words, on the outside of the wall and the inside of the wall, and this is known as Riegler's sign. Thumbprinting. This refers to mucosal thickening of the haustra due to inflammation and edema, causing them to appear like thumbprints projecting into the lumen of the colon. Instead of a smooth, regular wall, you have multiple indentations into the lumen. A lead pipe colon is a featureless colon. It really does look like the inside of a lead pipe. So in other words, there are no haustra, and this is usually typically secondary to a chronic colitis, most often ulcerative colitis. A toxic megacolon is a uniformly dilated colon where the transverse colon measures more than 6 centimeters in diameter without an obstruction. Most common causes of this are, again, acute fulminant ulcerative colitis and Clostridium difficile colitis. In conclusion, know the indication for the abdominal X-ray. Ensure the X-ray you are looking at is of your patient and is adequate quality, and then consistently apply a systematic approach to reading the X-ray. We usually use AbdoX to do this.